Top Med Talk.
Hello, this is Desiree Chappell. Welcome to our new series, Women in Anesthesia, inspired by the British Journal of Anaesthesia, March 2020 special online edition of the same name. We are celebrating the brilliant work by our female guests and want to highlight our conversations and lectures with them over the years. Have a listen to this fantastic piece. Hello, I'm Desiree Chappell, and this is Top Med Talk. I'm here with Monty Mythen, Editor-in-Chief of Top Med Talk. So Top Med Talk is in Orlando, Florida this week for the SPACI 14th Annual Perioperative Medicine Summit. Now, SPACI is the Society of Perioperative Assessment and Quality Improvement. And the Perioperative Medicine Summit is the Society's annual international multidisciplinary meeting, and it's typically held about this time of year. So we've had the opportunity to sit down with several of the board and directors for the meeting today already. But we also now have been graced with the presence of Dr. Angela Bader.
Thank you so much for inviting me.
Yeah.
I think this is a wonderful idea.
Oh, I love that you came and sat down. So, Angela, you're the director at the Weiner Center for Preoperative Evaluation.
Right now, I'm the vice chair for perioperative medicine. I transitioned in January.
Okay.
And David Hepner is the new medical director of the clinic.
Gotcha.
Yeah.
Interesting. And you're at Brigham.
Brigham, right,
yeah,
exactly.
Brigham. Okay.
That's a great title. Run that one by us again.
I know.
Which one?
Vice President.
No, Vice Chair.
Oh,
Vice Chair. So we are called the Department of Anesthesiology, Perioperative Medicine, and Pain.
Yeah.
And we have made that change specifically because of an interest in perioperative medicine. So I am now the Vice Chair of Perioperative Medicine. So with that change comes a focus on a little more broader view rather than being stuck in the weeds of the day-to-day preventing cancellations and, the patient issues and scheduling. So we're trying to take a little broader view. So, for example, Mass General Hospital is called the Department of Anesthesia and Critical Care, and I think that sort of emphasizes the difference in focus of the institutions.
Yeah.
So this is really, we're trying to head into a new direction.
Yeah, so the broader perioperative population health, health kind of stuff, or that broad?
So we actually are very focused on population management, or this is what we are trying to do. And this is requiring a big culture change for our hospital administration.
Just had this conversation with Amir.
Exactly. So I think the clinicians are behind it, but it is a big culture change. So my specific interest, so one of the things that we did get the hospital to give us money for, which was amazing, is starting in conjunction with the pre-op clinic, a center for geriatric surgery and palliative care.
Awesome.
Which is something that I honestly don't know if there is something with a similar... Are you aware of any, Monty, of a center for that with that sort of focus?
I'm not. No.
Yeah. You would if there was.
I was going to say,
you would know it, yes. And it's being run. The other part that I think is really great is it's being headed by a surgeon who's a woman surgeon who's boarded both in surgery and palliative care. She's one of the few surgeons in the country that's boarded in both surgery and palliative care. And she and I run a research group, which will be the research arm of this center. But the goal is really to focus on identifying geriatric patients that can benefit from preoperative interventions. And this is the pre-op clinic is one piece. I think this is trying to take it to a new level. So this literally, we're just having the first meeting, so we're trying to put this together from an organizational perspective. And I think what also is very nice is it's a multidisciplinary effort that involves geriatrics, palliative care, anesthesia, and it's going to live in the Department of Surgery because it's really a surgical initiative, which I think is one way of hopefully ensuring hopeful success, because with surgeons actually being involved in starting it, I think that surgical buy-in is going to be less of an issue. I think they'll be much more welcoming.
Yeah, I got a little skin in the game on this
exactly,
one.
Exactly.
So it's specialist care of the elderly surgical patient has become relatively common, and we've interviewed numerous.
So the POPs.
But it's the palliative care twist that I haven't heard before.
Exactly.
Yeah.
Can you expand on that bit?
Sure. So as Monty knows, because he was kind enough to have me lecture several times on this topic, I am very, very interested in high-quality shared decision-making. And Zara Cooper, who's the surgeon who's starting the center with me, we really need to have the mindset changed so that sometimes not doing surgery is the right
answer.
And as Amir said earlier, we are in this crazy race where everything is based on volume.
Yep.
So we really need to get away from that and really focus on value, which is patient-centered outcomes, over cost, instead of just doing the volume and not really caring what happens 2 months, 3 months, 4 months. Yeah. So our goal is to see if we can better standardize including high-quality shared decision-making as part of the overall geriatric optimization preoperatively. So I think that's a little bit different. And then secondly, I think, as Monty knows, we're very interested in elderly patients with cognitive dysfunction. And most clinics, at least in the U.S., don't even measure it. Do you measure that in the U.K., cognitive function preoperatively?
Not universally. So it's recommended now. And we, the clock face idea, the say the three things, the mini cog idea is often talked about, but not reliably universally delivered. I don't think it will be that long until it becomes standard.
Right. So
people are listening. People are listening.
Yeah, I think so too.
So I think, just to summarize very briefly for those who may not know, so we did some research. Surprisingly, it was the first time somebody actually looked at a preoperative population above age 65 and did standard mini-cog evaluations. And what we found, which was actually published in Anesthesiology, if anyone's interested, 2 publications.
Okay.
The first one showed that overall there's a 29% incidence of previously undiagnosed cognitive dysfunction. That's huge.
Yeah.
And if you were above age 75, it was 40%.
Wow.
And this
so
is
crazy.
Eliminating people that had a diagnosis already. So I feel like we've turned over a rock, and now what are we going to do with the results? And then we did a follow-up study which showed that people with previously unidentified abnormal cognitive stratification have longer lengths of stay. More of them go to a facility instead of home, and they have more complications. So it matters.
It does.
It matters. And it's a huge burden. And so now that we've sort of shown this, we have to figure out what to do.
So what is the next? I mean, what are you guys doing for the next?
I think it's a center for geriatric surgery.
Yeah, of course.
Well, it's not just having a center. What it is a population management where you identify these groups at risk, and you have a preoperative plan of how you're going to deal with that specific patient's issues, whether it's cognitive issues, frailty, etc. Now, you may be familiar with, I'm sure Monty is, that the American College of Surgeons has come out with new guidelines for how geriatric patients should be taken care of, and I don't think most institutions actually will meet those guidelines, because they involve cognitive testing and all of this attention to things that in most cases all we cared about was doing the
looked
volume.
over.
Don't even, just get the patient in, do the volume. Yeah. And then especially when patients are in situations where you don't have a pre-op clinic,
how do you even how can you even
they
manage?
ignore it.
Yeah,
so I hope that. And the reason they ignore it is because we get paid for doing the case. Yeah. And there hasn't been motivation to think about really optimizing preoperative care and having a goals of care discussion.
Well, I think so many times too, we never really look at our patients coming from the anesthesia world.
I know.
We don't look at our patients post-operative.
I think
there's not a lot of follow-up, especially if you're not in an academic setting.
Right.
You're not doing that. And so I think that's part of it too. They're fine when I drop them off.
Right. Well, I don't know, Monty, what you think the U.S. versus the U.K., but I think one of the big problems is that anesthesia people in training don't learn that this is important. Yeah. Do you teach that in the UK training?
We hope big time.
Yeah, see, that we're really missing. So I've been doing...
And I think the med students are getting it now much better as well.
Well,
do you think it's still behind here?
Oh, God. Well, I went to medical school at Harvard. We didn't learn it then, and the medical students I teach say... It's not
still not in there.
Right.
Oh, man.
So roughly speaking now, surgery in our institution is taught around a spine of perioperative medicine.
That's wonderful.
So that's the spine of the surgical training.
Yeah, that's what.
And those issues are mainstream discussion points.
Right.
And certainly in anesthesia training, it's mandatory now to do the shared decision making.
Right, exactly.
Understanding the challenges of the elderly surgical patients and end of life decisions.
Right. And I'm so, and it's funny because it is really difficult to get anesthesiologists who have not been trained to do this. They don't feel comfortable doing this. They're not incentivized to do this. You don't get paid for doing this. You only get paid for doing the case. So hence no pre-op clinics, no geriatric optimization. So I am really... it has been an incredible challenge to try to do this when the hospital administration is focused on how can we cut 15 minutes off.
Exactly. That's what I was going to say. The time stress. I mean, literally, it's a time stress.
Exactly.
You don't have it.
And they don't see the big picture. Right?
No.
Externally, we get the impression that if anyone's going to get it done in the USA, it's going to be you.
Monty, I am so thankful and appreciative that someone you would say that. That is so nice.
There's more to it than that. Than you, and particularly in your neck of the woods, where we think they're being... So if it's hard with the lowest hanging fruit,
exactly.
What's it going to be like for the rest of the country?
Well, that's why we need to push, I think, to get our anesthesia training systems more like yours. So that's one reason. The second reason is now, since I have talked with you, we're collaborating with Harvard Business School. And I work with Michael Porter's group at Harvard Business School, he runs the Institute for Healthcare Strategy. So I studied with him, and I became a fanatic. And so now it's not just about measuring quality, it's about measuring value, where, in fact, I just submitted a paper saying anesthesiologists need to learn how to do time-driven activity-based costing. And I think that if we don't have the tools to look at our processes and actually map things out, not just so you see the patient outcomes, but so you can really identify why shaving 15 minutes off a pre-op clinic visit and then adding on to length of stay and complications doesn't make any sense. Oh, so that's what I'm trying to do now as well.
So I don't know if you noticed it on the Twitter sphere, Angela, but the Royal College of Anaesthetists has just advertised for the founding director of the Centre for Perioperative Care.
Really? Maybe I'll apply. No,
no. We'd love you to.
Yes.
We'd love you to. Desiree's thinking about it as well.
Yes.
But what's interesting about that is the Royal College of Anaesthetists put their hand up to deliver the sort of perioperative medicine curriculum a number of years ago. Right. And now with the blessing of all the other colleges, physicians, surgeons, it's an interdisciplinary centre.
That's wonderful.
With them housing it initially, but with the aim of it soon to be able to work independently.
Yes.
And a clear statement that they're not going to be as bold as have the first director, I don't think, as a non-anaesthesia provider, but anyone who has got a passion for it, irrespective of their clinical background, could be the director in the future.
Right.
That's cool, isn't it?
Oh, it's wonderful. It's wonderful.
And I think that's how we're probably going to move the needle here eventually, too, is broadening that reach to all of our collaborative
I have a feeling, and again, this is from my experience, that my problem is not the clinicians. My problem is U.S. hospital administrators. Yeah. And we live in silos, and budgets are in silos, and my biggest challenge has not been surgeons, geriatricians,
because they kind of get it. I mean, they get it.
They seem to get it. And I'm, in fact, I lectured at the American College of Surgeons this year in a panel that Cliff Coe ran. And the room was full, and it was all about multidisciplinary collaboration, about ERS as well as geriatrics. So I think that it won't be an issue for clinical buy-in, but I'm really struggling with, now that we are hopefully transitioning to new payment systems.
Well, that's what I was just going to ask you about, the value-based care models,
value-based care
and
models,
these larger bundled payment type things.
Exactly.
I mean, it's we're gonna have to have these.
Well, they already are. I don't know if you're aware, but CMS, Center for Medicare and Medicaid Services, now has instituted a bundled payment for joints.
Yeah, the CR.
And the first metrics are coming out. And unless you can do costing and process mapping, now the risk is shared. And I think it really is funny. My own department, I asked the head of finance, how are we preparing for bundled payments? He said, we're not. And I wonder if that's what's happening at these institutions, but it's already here.
And is it mandatory now, or is it voluntary?
It's a pilot program that is I think it's in about 800 hospitals right now. And but I think that in fact, an article just came out in the New England Journal of Medicine, I think 2 weeks ago or 1 week ago. I had a slide about it showing the first results.
Yeah, I saw that.
Yeah, you saw that. Yeah. So the first results are showing that saving costs doesn't increase complications. And I think once CMS has learned from these pilot programs, I think it is going to expand. That's actually one of the main reasons why we were able to get the money to start this geriatric center, because the first kinds of surgery we're going to focus on is orthopedic joints. Yeah.
Because we've also heard in some interviews we've done that some programs, when they have choice, have chosen the bundle.
Yeah.
Yes.
And they've tried to transition and go through all the pain of it.
And then we had the discussion to say, wouldn't you want to have your joint done at someone who chooses the bundle?
Yes,
because that's kind of like a big sign that says we're good at doing joints.
Exactly. Well, I look at it, I'm hoping, with ERS and the bundle for ERS, that this will be a similar thing. And as CMS is doing it, we can sort of tweak the bundle and people will learn you have to do the bundle. It's not just pick a piece here and a piece there. And I look at it, in fact, that's what I discussed at the American College of Surgeons. I'm really hoping that a geriatric type bundle will be similar to ERS, hopefully in the future.
Yeah. So, in which that we are often asked about, who's suitable for ERAS, and there's this sort of perception they have to be young, fit people.
I know.
Whereas the big win is the geriatric patient.
Exactly.
Can you get grandma, grandpop home as quickly as possible?
Exactly.
That's where they'll thrive.
Exactly, because you don't have the opportunity to add value in the low risk groups.
No.
That's the
and I'm sure you agree. Home is the place to diminish.
Absolutely.
Get out of the hospital.
Get out of the hospital.
Familiarity.
I just had a surgeon the other day. I was talking to them about expanding the service into their service line, and they're like, "Oh, they're older, they're really high risk. I really don't think they're a great candidate." I'm like, "That's who we need to do."
Exactly.
You're saying everything that we want to take. We need to standardize the way we take care of and do this better.
Yes.
And finally, after talking to them, like, "Oh, it's like a light bulb goes off.
A light bulb comes on.
And it's just, it comes on, not goes off."
Yeah.
But can I, Desiree, touch on one last? I want to talk about an elephant in the room.
Which elephant? I hope it's not me. No.
So it's a recurring theme in discussing the future and the development of perioperative medicine that is, I don't know if it's unique, but it's more common in the USA, and it does go back to the founding of this society and this meeting, is the internal medicine doctor in the USA.
Yes.
And the anaesthesia providers not being as holistic practitioners, possibly.
Yes.
And it seems to create a little bit of a tension as opposed to a positive energy. Is that an elephant in the room?
Well, it isn't at the Brigham. And I have to say, the reason is we work collaboratively. We're not competing for the same space. And I think that may be unusual. And I think it's because, and I hope you will agree, that it won't happen with just the routine anesthesiologist. But if you have, depends on your institution, if you have people trained in perioperative medicine, for example, our geriatric surgery program will be collaborative with the geriatrician. We'll decide who needs to see a geriatrician based on risk algorithms, and then the geriatrician and the anesthesiologist will be in the same clinic, because I think we both add different value. And I think the problem that I've had with sort of having your PCP or your internist do your pre-op is they don't understand the operating room. Mm-hmm. They don't understand the physiology of what we do pre-op, intra-op, post-op, and I think that's the missing piece. So I don't really see it as an elephant. At least I think it can be made not to be an elephant if we understand that we have complementary
It's important
skills.
That it's not. That's the secret, isn't it?
For sure.
Well,
it's good for everybody.
It's good for everybody, and understanding that we have different areas of expertise. For example, I'm not going to manage someone's blood pressure, chronic blood pressure meds to get them ready for the operating room. I mean, that has to be done collaboratively.
We're not tablet doctors.
We're not tablet doctors, right.
Yeah, we're IV doctors.
Exactly. So
have you not heard that before, Desiree?
Yes, no, that's true.
I think I've said something very similar to that.
It's true. It's our mindset.
True.
Yeah.
It's our mindset. I don't even know how to prescribe pills anymore.
I think I've quoted it before. I think it's David Lebarski said, actually, a meeting here, he said, I don't understand all that preoperative bit. There's a point you get to where you say, step away from the patient. We're going intravenous.
Yes.
I love it. I could see him saying that too.
And that's why you want to get the ERAS thing done, because as soon as you get the IV down, it's back to the tablet doctors.
Right. Exactly.
And that's right and proper.
And
it's the right thing to do.
I don't know how to adjust a medicine that takes 3 months to have its impact.
Exactly.
I'm kind of bored after 30 seconds.
I mean, I really think we have complementary skills, and I'm sure, I don't know if this happens in the UK, but I cannot tell you how many people that do get evaluated by their PCP, and I'll get this note that says "okay for regional" or something, and I'm like, what does that even mean?
Totally.
Yeah, but I think we've discouraged that, and so we really are trying to show that we can work together and have complementary skills.
Well, so when we take the example of the geriatric patient, we have done a lot of interviews in this area. I think our general consensus in the UK from the Royal College of Anaesthetists perspective is we really, really want a growth in geriatricians who specialise in perioperative care of surgical patients, because they have that home-to-home view, that interface with social services, that knowing the medicines that we think help that hurt.
Right.
And actually, we want them to be team leader in that situation.
Exactly.
But with us to do the intravenous bit.
Right. I think it has to be collaborative. And, for example, at this SPOCI meeting, we are also, if you look at the topics, we're heading more in that direction. For example, the geriatrician that I collaborate with is giving a lecture here on Saturday about frailty, which I don't think ever would have happened, when we started this society. But now we realize that we have to work together with the geriatrician, and they can help us learn how best to deal with these frail patients and work collaboratively. The one piece that really I don't know what to do with is, now that we are identifying all these patients with abnormal mini-cogs, and now that it makes a difference, I don't think we know where to go with that, to do because it's a huge percentage.
Yeah.
So I'm hoping that our research will head in that direction, because dealing with frailty is pretty common, but now that we understand this burden of high abnormal mini-cogs, what does that mean? It's not a diagnosis. What do we do with it? I look at it sort of like a MET scale. If your MET scale is low, something's not right, but you don't know what it is. Yeah. And I think the mini-cog is kind
great
of the
way
same
to
thing. So we don't really know what to do with it.
I think the thing that is resonating back home is that if you did the mini-cog evaluation recorded in your preoperative assessment thing, and next to it you immediately recognise that there are some commonly used drugs that you should not use.
That's true.
And there's a need to give an explanation that you're cognitively not quite on the money, which you probably have got a few clues about.
Yes.
And that means that certain things might happen post-operatively that we hope will get better, but they're more likely to happen.
Right.
Those three things are a good start.
It's a good start. Yeah. Or even changing nursing care on the floor to put in delirium prevention, which we are doing for our orthopedic patients now, but it isn't routine all over the hospital.
It's such a huge education piece, though, and usually what I have found is if you start something like that, it bleeds into everybody else.
Hopefully.
I mean, hopefully, but, once, I think that's one of those things that kind of, once you get it, then you're kind of like, oh, I need to be doing this, like, kind of for everybody.
Right. So our goal is to start with orthopedics, because the hospital is motivated because of CMS, and then to spread across to other surgeries.
Yeah.
And that's a lot of, in the UK, it's the second commonest, the second biggest bed user for surgery is the joints.
What's the first?
Caesarean section.
Oh, interesting. Yeah. I didn't know that.
It's even bigger here.
I think ours is...
Because your length of stay is much longer.
Yes, I did not know that.
Yeah,
so there's a second, orthopedics is, even with the move towards day case, it tends to be that geriatric frail elderly patient isn't getting the day case joint.
Right.
And then they're at risk of getting sucked into the system.
Yeah.
And then they're discharged not to home.
Yes.
That's the
exactly.
challenge.
Oh, that's very interesting. I did not know that.
That's cool. Yeah. Well, Angela, I hope this was easy.
I was nervous, but Desiree, you're an excellent interviewer.
Oh my gosh. Well, thank you.
It's so much.
This
really
is a fascinating conversation.
And I hope that you're enjoying our meeting.
Love it.
We're planning it for next year again. And hopefully you'll be able to get a lot of the speakers, because there's some interesting topics being discussed.
Yeah. Hopefully you can help us with your friend. Is it Human?
Human is Human. Oh, I'm sure he would love to.
Yeah, let's do that. Thank you so much. Hold on one second. We want to say goodbye, and so cheers to everyone.
Thank you so much, and thank you for being here. And hopefully you're enjoying our SPOCI meeting. And,
wonderful.
And thank you to Monty for helping us start the organization.
It's great. Thank you so much. Cheers.
All right.
Thank you. Top Med Talk.
Desiree Chappell here. Just a quick reminder: subscribe to Top Med Talk. We're a daily source of news and conversation focused on perioperative care. We bring you all the latest talk from all the major conferences in the perioperative space. We can also be found on Twitter, Facebook, LinkedIn, Instagram, and we now have a free mailing list with special offers and additional goodies for subscribers. Go check us out at topmedtalk.com. That's www.topmedtalk.com.